Welcome, everyone. Thank you for joining us. My name is Brooke Cruz with MCD Global Health. So Dr. Tisha Titus will be starting our presentation off today. Dr. Titus, are you ready?
I am. Good afternoon, everybody. My name is Dr. Titus. I'm an adjunct associate professor at Emory University in the Department of Family and Preventive Medicine. I'm a fellow of the American College of Preventive Medicine, and I'm a person with acquired disabilities, with my first permanent disability at age 7, my first relapsing and remitting disability at age 32, which became my second permanent disability at age 50. And I am here with the ladies of MCD Global Health to talk about implementation tools for practitioners for disability-inclusive preventive screenings. With me today, we have Ms. Letitia Brown, who is a self-advocate and a technical advisory group member, Brooke Cruz, who is the Associate Program Manager of MCD Global Health, and Corey Powell-Haggerty, the Program Manager of MCD Global Health. We have no disclosures. And this presentation has been approved by the ACCME for continuing medical education credits. At the conclusion of today, we would like participants to be able to identify at least 3 common barriers to people with disabilities that face during preventive screenings, to list 1 or 2 accommodation strategies for at least 1 USPSTF A or B recommended screening, and to identify at least 2 changes that your organization can make to improve screening accessibility for patients with disabilities. Before we begin, I think it's important that we discuss what defines a disability. Per the Americans with Disabilities Act, it is a physical or mental impairment that substantially limits 1 or more major life activities. 28.7%, nearly 1/3 of the United States population, is considered disabled, and that is physical, mental health, sensory, as well as intellectual and developmental disabilities. 8 out of 10 people acquire their disability, like myself. And we know that disabled people have decreased access to care and lower quality of care. With that, people with disabilities also face a higher disease prevalence. They are 1.5 times more likely to have cancer and hypertension, twice as likely to have diabetes, and 3 times more likely to have depression. Yet they receive fewer preventive screenings, specifically mammography and cervical cancer, which may be related to financial constraints. It is important to be mindful that the disparities that we see result from systemic barriers and social determinants of health, including a reduced education attainment, decreased employment opportunities, and a lower or potentially fixed income, not the disability itself. Before I make my final point, I'd like to talk to you about one of our technical advisory group members. This person identifies as hard of hearing and variably nonverbal. They visited an emergency room with cardiac symptoms. And despite advocating strongly for an interpreter, this request was repeatedly denied, and they became obviously frustrated. The practitioner then referred them to psychiatry instead of providing them with medical care. And they were later hospitalized with a high D dimer. And in their own words, he literally could have killed me. This is far from the only story that I or others have. These incidences can feel like a real threat to safety and care. Patient distrust isn't just from ignorance or failing in the patient. Patients have had very, very bad experiences, and these experiences are a legitimate trauma response to incidences within the medical system. What I've just described to you is healthcare trauma. And people with disabilities often have increased engagement within the healthcare system. And with that, there's a higher incidence of gaslighting, minimization, not being heard, or feeling like they have to fight for their own advocacy, as I just described. That also means that those actions and those frustrations can often be interpreted as poor behavior, when in actuality, that behavior indicates an unmet need. And in this instant, that patient needed assistance with communication to be able to receive care. So this is our reminder that all patients should be treated with trauma and disability-informed care, dignity, and respect. We need to meet them where they are, not where we want them to be or where we think they should be, because they are doing their imperfect best to respond to emotional pain and/or distress with limited tools. And with that, I think that this is a salient reminder for us as physicians to be open and supportive of patient and medical advocates within the care setting. With that, I will turn it over to the ladies of MCD Global Health, and they can talk to you about screening for all.
Thank you, Dr. Titus. Hi, everyone. My name is Corey. So Screening for All is a CDC-funded project through the National Center on Birth Defects and Developmental Disabilities. And the goal is to make preventive health screenings more accessible for people with disabilities by developing practical, implementation-focused resources for both practitioners and patients. But these changes don't just benefit people with disabilities, they also can improve care for everyone, which is why we called it Screening for All. This work was guided by a technical advisory group made up of people with disabilities, caregivers, and family members. Over a series of 18 weekly video conference meetings, we created and shared plain language presentations explaining the procedures for all 29 USPSTF A and B graded screenings and gathered TAG members' feedback about barriers and recommended key supports for people with disabilities. TAG members also shaped our decisions about which resources to create and provided feedback on the initial drafts of those resources. In addition to our work with the TAG, we also conducted a comprehensive literature review and worked closely with experts in disability, preventive medicine, and clinical care, including Dr. Titus, to ensure the materials were practical, accurate, and grounded in lived experience. Now let's hear from Ms. Letitia, a member of our technical advisory group, who will share her experiences with 4 screenings, and Dr. Titus will offer clinical insights along the way. Ms. Letitia, would you start by telling us a little bit about yourself, please?
Good afternoon, everyone. My name is Letitia Martin. I'm a 43-year-old African-American woman living in Dayton, Ohio. I live with cerebral palsy, which affects my right arm and both of my legs. I have learning challenges due to my cerebral palsy and mental health challenges. I currently have Medicaid, medical insurance, and I receive assistance with my daily living tasks like showering, dressing, meals, toileting, and house cleaning. I use my power wheelchair for 12 to 13 hours a day.
Thanks so much, Ms. Letitia. We want to share a note for webinar participants. I will be having a conversation with Ms. Letitia about her experiences with 4 different preventive screenings. And as we go, I will be modeling an example of plain language descriptions and using visuals to help talk about the procedures when we're talking together with Ms. Letitia. And as practitioners, I'm more than certain that you are aware of the medical terminology here, but we want to demonstrate the language and visuals that patients might find helpful. And in fact, as we'll learn later in this presentation, plain language descriptions and visuals are important accommodations for many patients. And also, at the same time, please keep in mind that Ms. Letitia has already learned a lot about these screenings because of her role as a technical advisory group member with us. But some patients who are less familiar with these screenings might benefit from slower, more step-by-step explanations and visuals of procedures. So with that, let's get into it. Okay, Ms. Letitia, we're going to start by talking about your experience with breast cancer screening. The USPSTF recommends mammograms every 2 years for women ages 40 to 74. Ms. Letitia, at 43 years old, you are in this age group and should be getting mammograms every 2 years. The mammogram is where they put your breasts into a machine that squeezes each one between two plates to take an x-ray. There are other ways to check for breast cancer, but the mammogram is what doctors usually try first. Ms. Letitia, did you get a breast cancer screening when you turned 40?
Yes,
How did that go?
it did not go so well.
Can you tell us a little bit about what was challenging about it?
It did not go so well because, in my opinion, the staff were not used to for a lack of a better word, dealing with an individual with a disability. I felt degraded. My staff was disrespectful, and I told her that I didn't want to do this again.
And this was, and it was the staff of the clinic that was disrespectful to your staff?
Yes,
And what kind of screening did they do that first time? Was it a mammogram?
yes.
And what was the biggest issue that you had during this first mammogram?
The communication was one. They didn't realize that I'm a person with cerebral palsy, therefore I cannot sit up straight to where my rest can be put on the camera thing very well. So what they tried to do is put blocks in to help me sit up straight, but that didn't work. So that year I ended up not getting my mammogram.
They tried to take the mammogram picture, but it didn't come out clear, right, that first time?
Correct.
And so what did they try after that? Did they come up with any other ideas for how to help you get the mammogram?
No, I mentioned to them that they should have a conversation with my doctor and for me to get a ultrasound, and they said that they would do that.
Okay, so yeah, my next question for you was going to be if you had ever been offered other types of imaging like a breast MRI or an ultrasound.
An MRI, no, but a ultrasound, yes.
Okay, what supports do you think you would need if to do the breast MRI? What do you think you would need to be able to do this procedure?
First of all, I would need my Sarah or Joe sit to stand. I would need a height adjustable examining table, and there would probably need to be extra staff on standby for physical support.
Okay, getting positioned onto that table. And what about staying still for the procedure? How would that be doable for you?
That I'm not sure of due to the fact of me not having one, but there is a possibility that I would have to be slightly sedated.
Okay. Dr. Titus, we'll bring you in now, Dr. Titus. From a medical perspective, what do you think about Letitia's experience? She's gotten a breast ultrasound. Do you think that she has received appropriate breast cancer screening?
Technically, no, because the mammogram is the standard of care. And although we do use MRIs and ultrasounds, we use them as an adjunct or an accessory tool on top of the mammogram. That said, as a preventionist, I much prefer some screening over no screening. And we have one option right now that is effective However, I do think that Miss Letitia knows exactly what it is that she needs, and that there would be a possibility to try again for a mammogram to see if we couldn't potentially get different results.
And Dr. Titus, what are some other accommodations that they might be able to try for Miss Letitia before totally dismissing the idea of the mammogram?
I think the height adjustable unit is extremely important to be able to get that to her level while she's seated in her chair. I also think that the extra staff, this may be not just a single support staff person, but this may require 2 or 3 people to help get her into the very particular position that's required for mammograms, which is with the chest out and an arched back, which might be very difficult for her to accomplish. So there may be the need for some bolsters or some wedges with perhaps 2 or maybe 3 additional staff. And as she also suggested, she may need a little bit of light sedation to help her to be able to stay still in that position for the imaging. But I do think that those options are doable.
Okay, thank you, Ms. Letitia and Dr. Titus. Now let's turn to another imaging-based screening with slightly different positioning needs, and this is the osteoporosis screening. Okay, so the USPSTF recommends osteoporosis screening for women 65 and older, and for postmenopausal women under 65 who are at increased risk. And Ms. Letitia, you're 43, but if we go just by age, it looks like you aren't old enough yet for the screening, but you are at increased risk because you use a wheelchair. And now the usual exam for this is the DEXA scan. This is the one that takes pictures of your bones while you lie on a table, and we're trying to see if the bones are getting weak. Have you been screened for osteoporosis with a DEXA scan?
No, ma'am.
Do you think this screening is important for you?
Yes, because I could be losing strength right now and not even know it.
And what have your doctors told you about your risk for osteoporosis so far?
Unfortunately, nothing.
Okay. Whenever you do go to get your DEXA scan, or get this osteoporosis screening, what do you think some of the obstacles might be?
Staff support,
Okay.
height adjustable table, possible sedation, I'm not sure. And I would also need height adjustable table and my Sarah sit to stand.
Mm-hmm. What about the part on this screening where you need to change positions? Would you need staff to help you
Yes,
with
that would be
moving your legs?
I would need physical support, yes.
Okay. So getting up onto the table transfer, and then support from staff to help when it's time, help hold Letitia's body when it's time to change position.
Yes.
And so, Dr. Titus, I'll bring you in now. There may not be a height adjustable table or a good way to transfer her to the table, perhaps for the DEXA scan sometimes. So what other options might work for Letitia for this osteoporosis screening?
So we do have the option of being able to use a heel scan. It is not going to provide us with the same amount of information as a DEXA scan, but it would still be able to give us a general picture. And I think in this case that is a very reasonable option given the obstacles that we have.
Okay. And where should Letitia begin to make sure that she gets the screening since she falls outside of the standard guidelines? What would you recommend? Where should she start?
So I think there's actually 2 places where this could start. The first one being mentioning it and having that discussion with her practitioner, either family medicine or OB-GYN or whoever it is that she's seeing that has a vested interest in her overall health as well as her bone health. But this would also be a good place to contact a patient advocate to help advocate for her for the screening that she needs and to help liaise with those offices that might be able to help her.
Okay. Right, because it's one challenge is just knowing what accommodations you need, and the other challenge is just making sure that you have enough support, whether that's a medical advocate or a caregiver, someone on your side to help advocate for you too. And so breast cancer, osteoporosis, these are two examples of these imaging-based screenings. They have unique challenges around positioning. And then also in the case of osteoporosis, just understanding your eligibility for the screening and collaborating to find alternative screening methods if needed. Next up, we want to discuss two more screenings. These next ones involve more invasive physical examinations, so cervical cancer and colorectal cancer screening. The USPSTF recommends cervical cancer screening for women ages 21 to 65. And Ms. Letitia, since you're 43, you should be getting this screening every 3 to 5 years, depending on what test you get. A cervical cancer screening can be done with a pap smear or HPV test, where a doctor uses a small brush to collect cells from your cervix. The typical position is to have you lying on your back with your feet in stirrups. So, Letitia, have you had cervical cancer screening?
Yes.
How have those experiences been overall?
Are we referring to before now or now?
I think just throughout life, when you have had the screenings, like,
Before now, it was horrible, and now it's better, but this last time it did not happen at all.
okay, kind of mixed experiences. And so the next question I have for you is if you could talk to us about some of the barriers that you've had with the screening in the past.
At first, I did not know what to expect, so I could not offer the accommodations that I feel that would have made it easier.
Mhm.
So I went into what I like to call spastic shock.
Mhm.
Because when you have a disability and you have a big weird object going in your body and you're not told what it is, what it's going to do, and all that. That's why I went into spastic shock and about kicked the doctor in the face. And then the second time that I had this done, it was a smooth um a smooth situation because I knew what was going to happen. I knew what accommodations to ask for, and so that is why it was a smooth transition. I mean, a smooth situation.
Yeah. Tell us about some of the supports that help you with this screening.
My doctor's office has the height adjustable table, and it's not the one that you see in the picture. It's totally different. I bring a support staff and my Arjo Sarah sit to sit.
Okay. And tell me, is it important for you to get this screening? Do you feel that it's important for you?
Yes, because I could walk around and have cancer and not know it. And if it can be prevented, I want it to be prevented.
Right. How often do you get screened for cervical cancer usually?
At first it was once a year. Then when the doctor saw how difficult that the preparation was. She said once every 3 years.
Okay. What do you think about doing a self-collected HPV test? Do you think that would be a good option for you?
No, that is totally impossible for me to do due to my physical dexterity issues.
Okay. Dr. Titus, what would you add to this conversation around cervical cancer screening for someone like Letitia?
So first, I just want to say that I'm a bit disappointed that her last screening didn't actually happen, even though it sounds like she still had a little bit of time before her next official screening was due. But I think that there are a number of options that we can look at here. There are a multitude of positions that we can use to collect a specimen. So although on the table and in the stirrups is the most common, there are others. There may be the need for additional assistance. Self-collection would potentially be a possibility if she was willing to allow the collection to be done by either the office nurse or perhaps another staff member at the clinic that is also qualified to do that. It is a self-collection. She doesn't have to do it herself. She could allow somebody else to do that for her if she's comfortable, and that could be done in the medical setting to make sure that she has the resources that she needs. And I think it's also important that these guidelines are under revision. So even though currently it is every 3 to 5 years, but that may change. And I sincerely hope that Miss Letitia is able to get her screening the next time she goes in.
Okay, great. Thank you, Dr. Titus. And we have one more screening to talk about with Letitia. It's the colorectal cancer screening, and this one has some unique preparation challenges. So let's get into it.
Also, if I may add to the previous screening, I'm gonna also add a medical advocate would be
Yes.
excellent in that situation, because they will ensure that we're not going to go into the situation that Dr. Titus was talking about, but they would ensure that my last pap smear did happen in the way that was most convenient for me and my staff.
Yeah, thank you so much for adding that in, Letitia. That's the importance of a medical advocate in this situation is key because it might be a difficult conversation to have just with you and your doctor alone. And that, I think that would be a really helpful person to have on your side for this. So,
And if I may add, I would recommend a medical advocate for all medical procedures. It's just a good thing to have because they will ensure that we get the accommodations that we need. They will ensure that our rights as a patient is not violated. So it's just a good thing across the board.
thanks for adding that in. We'll get into our last screening now, the colorectal cancer screening. And the USPSTF recommends colorectal cancer screening for adults ages 45 to 75. And how often you get screened depends on what type of test you take. And Ms. Letitia, you will become eligible for the screening in 2 years when you turn 45. And the colorectal cancer screenings look for cancer in your colon and rectum. This can be done in a couple of different ways. So there are tests where the doctors examine inside your body called colonoscopies, where a few days before you drink a special liquid that makes you go to the bathroom a lot. And then doctors use a camera on a flexible tube to look inside your colon. And there are also at-home tests called stool-based tests like Cologuard that can look at your stool for signs of cancer. So, Ms. Letitia, have you had a colonoscopy or another type of colon cancer screening?
Can I please give a forewarning for this
Okay,
conversation? In this conversation, there's going to be some information given in this conversation that I'm going some language that I'm going to use that I don't want anyone to take offense to. I don't want them to think that I'm trying to get my staff in trouble, but I'm a very blunt person, and so this conversation is going to require me to use some blunt language.
okay. Have you, so you have not had this screening yet, right?
No.
Is this one that you feel is going to be important for you, this screening?
Yeah, absolutely.
What concerns do you have about this screening when it comes time for you to get it?
First of all, for the colonoscopy itself, that will be physically impossible due to my staffing schedule hours as they are right now, without a doctor's order like from Dr. Titus writing me a letter of medical necessity for hospital stay for preparation, and the day after to make sure there's no allergic reaction or medical reaction to the procedure.
Yeah, we've talked a little bit about the bowel prep process is what would be really challenging for you because of your staffing schedule. Can you tell us a little bit more about why it's that 48-hour period before the actual colonoscopy that would be really challenging for you?
Because my hours are from 8 to 1, and then I have alone time from 1 to 5, and then I had hours from 5 to 9, and then I receive remote remote supports from 9 to 8 or 7, depending upon the day of the week that it is.
So the hours that your staff is available to help you, they're not available around the clock for you, and you would need
No,
more assistance.
and also I believe after this procedure I would lose staff because no one wants to deal with somebody else's bowels.
Mm. What do you think about a stool-based test like Cologuard? Do you think that might be a good option for you?
That would be a better option, but again, I think that I would lose staff because no one wants to deal with somebody else's bowels.
Dr. Titus, I'll bring you in now. What would you add to this conversation?
So I think that the stool-based test is the most reasonable to accomplish a good screening test. And I do think that there's the possibility of perhaps getting assistance from a local medical school or a nursing school that would be willing and capable of actually handling the stool for the sample submission. I definitely think that's a possibility. However, should that test come back with something positive and she needs a colonoscopy for further investigation, then we really do have to look at that very, very strongly worded letter and the prior authorization for medical necessity for hospitalization to help get her through the bowel PEP, through the procedure, and to make sure that she comes out on the other side as far as a recovery standpoint and is returned to her staff at the same level of function that she had left them.
Okay, thank you so much, Dr. Titus, and thank you so much to Letitia for sharing um, your experiences with these screenings. And I just want to emphasize that for someone like Ms. Letitia, it's so crucial to plan together with her the smaller steps of all of these processes that may be taken for granted. How will she transfer to an exam table? How will she change positions? What level of support will she realistically have from her staff or from office staff to carry out all the steps of a given screening, wherever that's in her home or the office?
Excuse me, but can I honestly answer right now today? None.
None, what was that, Letitia? None what?
None to the response that you just asked. How would I get the supports? I wouldn't get any. Because the doctor's office would say we don't have the staff to support you. I would lose the staff that I have now because they would say it's not in their job description, and it will be impossible to do because the without the orders of orders of recommendation for hospital stay, it just would not be possible because staff would say it's not in my job description to do this, and
Yeah.
the, the office doesn't have height adjustable table.
Okay, so there's challenges nonstop. Like there's always, and you're very used to have all of these roadblocks that come up.
Yes.
Yeah. We gotta move on to the next part of the presentation, and thank you so much, Letitia, for adding that part on. And I'll just say that yeah, this planning ahead for the kind of accommodations that Ms. Letitia would need, planning ahead sets everyone up for less frustration. Next, we wanted Corey to share a look at a few key accommodation considerations for the same screening for other disability types.
Thank you, Brooke. So people with other types of disabilities may face different barriers across these same 4 screenings. For example, those with intellectual and developmental disabilities, or IDD, may experience sensory overload from the bright lights, the sounds of the imaging equipment, or unfamiliar clinical environments. Anxiety is also common, especially with intimate procedures like pap smears. And communication is crucial. Many patients benefit from concrete explanations and using visual supports and plain language. This is particularly important for complex preparation instructions like those required for colonoscopies. For people with sensory disabilities, including those who are deaf, hard of hearing, blind, or low vision, there may be some orientation challenges and communication barriers. For example, lack of interpreters, captioning, or screen readers. We also have to consider that sometimes for patients, there may be some privacy concerns about sharing sensitive information about their bodies through an interpreter. As much as interpreters are professionals who should adhere to patient privacy, it's important to be aware of that dynamic. These barriers are not necessarily mutually exclusive to specific disability types, and many accommodation strategies support patients across multiple disability types. Also, not every person with the same disability needs the same accommodation. So, and this is key, ask each patient about their needs and tailor your approach accordingly. Patients are experts of their disability and their accommodations. So how to address these barriers? In the rest of our presentation, we're going to look at the resources that we created, which provide direct recommendations for some of the barriers we just discussed. One of the most consistent themes that emerged from our TAG discussions was how patients with disabilities are forced to fight for accommodations that should be standard practice. Time and again, we heard that supports and accommodations are either unavailable or require extensive advocacy just to access. Insights from those with lived experience with disability became the foundation for our solution. Our goal with the Screening for All project, was to create actionable tools that support patients in accessing accommodations and help practitioners understand their role in providing them. These resources are designed to foster collaboration with patients and serve as a starting point for discussions about their needs so that they can get the screenings on time. So how do you begin putting accessible screenings into practice? Let's explore the tools that we have developed. So in part 2 of our presentation, we'll introduce you to the tools that we created and discuss some of the major implementation barriers we wanted to address in the design of the tools. Then we'll look at the implementation plan before sharing with you a few ideas on how to start getting connected with local disability organizations to support you on this path toward more inclusive care. First, what are the tools? So all of the tools I'm about to reference are available on our website, which we'll share in just a bit. First, our implementation guide provides a structured approach to make your practice more accessible for patients with disabilities. This comprehensive resource includes 4 key components: a data summary showing health disparities and screening gaps, evidence-based adjustments and adaptations for improving accessibility, a practical 24-month implementation plan broken into manageable phases, and practical resources that include ready-to-use clinical guidance and office staff resources. The guide is designed to help you systematically improve preventive screening rates and enhance the quality of care for all patients, especially those with disabilities. We created 3 new kinds of tools for practitioners. Practice considerations provide clinical guidance for adapting osteoporosis, breast cancer, and cervical cancer screenings for people with disabilities. And we also created a general guide for considerations around the questionnaire screenings. Quick reference guides are 2-page summaries of the practice considerations that you can use during patient visits, highlighting critical accommodation possibilities for patients with sensory, mobility, and intellectual disabilities. And then office staff resources include guidelines for creating accessible intake forms and signage to help spark those conversations with patients about their accommodation needs. These resources are designed to be adaptable for a variety of different practice types and sizes and help your entire team create welcoming and accessible experiences. We've also created some practical and plain language resources that you can share with your patients to help them navigate their preventive care. The yearly checkup guide explains how patients can use those annual visits for screening discussions and planning. The screening timelines show different screenings, show when different screenings are recommended by the USPSTF. And the healthcare accommodations checklist helps patients identify their specific needs before the appointment. And finally, individual screening guides provide explanations of breast cancer, cervical cancer, colorectal cancer, and osteoporosis screenings, and include some screening-specific accommodations checklists and space for patients to write out any questions that they might have for office staff, practitioners, and even insurance companies to ensure that they get the care that they need. We also created a general guide for patients about what to expect during the questionnaire screenings. And I'll pass it over to Brooke to talk about the website.
Yes, so our Screening for All website, found at ncd.org/screening-for-all, serves as a hub for the disability inclusive preventive care resources we created with separate pathways for healthcare professionals and patients with disabilities. We will send out the link to the website in the chat, or you can snap a picture of the QR code now if you'd like to pull up the website on your phone.
Within the website, we created a resource library, which is a curated collection of over 280 existing videos, e-learning trainings, toolkits, and additional resources for both healthcare professionals and patients. We created this database because while many disability competent care resources exist online, they can be hard to find. The goal of the resource library is to be a one-stop hub for learning about disability-inclusive healthcare, bringing together the wealth of existing high-quality materials that are already out there with our newly created tools. Users can filter by audience, cost, CME availability, format, disability type, health topics, and also the year published. You can also use the search bar at the top to type in keywords for whatever you're looking for.
And we hope that if we have missed anything, people can let us know. We can add them, and our contact information is at the bottom of that resource library page. So before we dig in a little bit deeper to the implementation plan, I'll touch briefly on some of the guiding principles behind how these resources were designed. So we wanted to make sure that they address not only patient barriers, but also barriers for practitioners. So the major ones we were considering are knowledge gaps. These can be tricky because you may not know what you don't know. It could be difficult to know where to begin or to find appropriate trainings and make time to complete them. Corey, can you, yeah. And then, so that's where our resource library and implementation plan come in. In the resource library, you can find descriptions, time estimates for each resource, so you know what you're getting into. And then the implementation plan gives you step-by-step guidance, and you can follow along with a checklist to make sure and keep track of which resources you've reviewed. And because in that implementation guide, we're also linking you to the world of other resources that exist, not just our own. And we've included links to both audit tools for not just ADA compliance, but also disability inclusive soft skills. And so these will help you assess where you are and track improvement. Communication challenges can be another hurdle. And so to help with that, we've curated a lot of links to best practices for inclusive communication inside our implementation guide as well. So next slide, please. Some practices might be concerned that they can't afford accessible equipment or that they don't have time for implementing major changes. And to address this, our guide features the quick reference guides to help you review that basic accommodation information quickly at the point of care. And then also we included information on tax incentives and grants for funding accessible equipment. But keep in mind that improvements might not always mean buying new equipment. And so in the guide, we give you some ideas for how you might make small incremental changes or use the equipment that you already have differently if big equipment purchases aren't immediately possible. So finally, many practices don't have a standardized way to track disability status and accommodations of their patients. And so in our guide, we link you to expert guidance from a group called the Disability Equity Collaborative, and they have information on best practices for documenting disability status and also for training office staff on these practices. So I think we'll go ahead and skip the next slide, Corey. The implementation plan, this is an overview of the plan. So this isn't meant to be a rigid checklist that you follow and then you forget it later. It's designed to help you build something flexible, something that works for your practice, and a system that is for ongoing engagement with your patients. Moving beyond just compliance and moving toward genuinely inclusive care. So this is a 4-phase plan that's designed to be realistically accomplished in about 24 months. So the time frame may vary with your practice, and the phases can overlap. You don't need to finish one before you start the next one. So the first phase is the foundation, and the idea here is to prepare and ground yourself in disability awareness, choose an accessibility leader, and build a support network with local disability organizations. Phase 2 is development. You'll establish new processes, you'll map out your workflows, you'll develop your procedures for accommodations, and you'll set up your electronic health record system. Phase 3, is implementation, putting everything into practice, starting with patient outreach, and then offering accommodations to patients, and then checking in also regularly with staff so you can figure out what's working and what's not and adjust accordingly. Phase 4 is monitoring. You want to make sure that these changes are sustainable. So here's where you'll solidify your data collection systems, establish continuous improvement processes, and just plan for long-term stability. Try to measure your impact on screening rates and patient satisfaction. So we're hoping that this allows you to gradually build capacity for lasting change that'll serve not just your patients with disabilities, but also all of your patients. And I think just as if you want to go ahead and just show this slide all at once, Corey, this talks about some of the need for more resources and just how we hope that you will build on this work. There is a need for more resources like plain language guides, and you could create your own too. If you work together with local disability organizations, you can come up with really great content as well. And we would encourage you to give it a shot. There is a lack of CME credit training for disability competent care, but there's a wealth of non-CME training. So we really encourage you to go check out our resource library and look into the trainings that exist. Even if you don't get credit for them, we really encourage you to go do them. And some do include CME credit. So, and then also the Disability Equity Collaborative has work groups that can be the start of your support network that we hope that you will build on. And we'll give you some links to this in the email after the webinar. So to close, I want to emphasize what one of our technical advisory group members shared with us. She said, partnerships and community engagement are so valuable for this work. Practitioners are not alone. They don't have to be an expert in accessibility because there are experts. So we just want you to know there's a whole network of disability experts who want to partner with healthcare professionals and make care more accessible. Here listed, you'll find a couple of resources. We'll also send this out to you after the webinar. But at the local level, you can reach out to Centers for Independent Living, your state's Protection Advocacy Agency. And for compliance questions, the ADA National Network offers free technical assistance. Accessibility, the National Disability Rights Network can do document accessibility reviews. And the state assistive technology programs can provide free information on assistive technology. So in closing, we hope that you try out the resources we created and those we curated in our resource library and build on them so they work for your practice and your patients. Start with one small change today and let that momentum carry you forward. And that wraps things up for us. But thank you everyone for your participation, for your support, for your questions. If you have any further questions, please email Corey or I, and we would love to get in touch and discuss. So thank you everyone again, and hope everyone has a wonderful day.